increased during this COVID pandemic. And what you also see is that the health effects of being lonely, feeling lonely, does have a very strong effect on not only our mental health, but also on our physical health, because it affects sleep quality, but it also affects other kinds of health risks, like, for example, the risk for a stroke. If you have poor social relationships and you would self-report as feeling lonely, your risk of having a stroke increases with 32%. So loneliness is very unhealthy. So what we can then conclude is that both the quantity and the quality of our social ties is really important for our health. And importantly, they have established in a lot of longitudinal research studies a causal relationship between our physical and mental health and the quality and the quantity of our social ties. So one of the defining models is by Holt, Lundstad, and Smith. And what you can see here as well is that the outcome, so morbidity, mortality, of course, there are lots of physical biomarkers and physical explanations to certain health outcomes, including medical adherence and compliance. But there are also, as you can see here, at the beginning of this model, there are social connections that define and explain how people's psychological responses are, but also what their lifestyle behaviors are. And these in turn predict and explain morbidity and mortality. So loneliness, social isolation, they relate to certain appraisals, experiences of stress, mental and physical well-being. If you feel very lonely and very isolated, the likelihood of living healthily is also smaller, because why would you? There's an increase in risk-taking behaviors like alcohol or substance abuse, lowered physical activity, poor nutrition and sleep. So all these elements interact, but what I wanted to stress here for you is that there is a causal relationship between social ties and health outcomes. Then you can, of course, ask yourself, how then does this influence work? So how do other people influence our health behaviors? So that is this, that specific line. So one possible explanation of that influence is the role of social norms, which I already briefly talked about, but also social control on health behavior. And this is another model by Umberson that also shows how social ties are causally related to health behaviors. And what these authors also emphasize is meaning giving, so norms in our social environments, but also social control. And here are the social ties again. And I will talk about what social control is more in detail. So what most researchers then agree on is that our social ties influence our health behaviors mainly through norms. And norms are very much a focus of social psychology and health psychology. So you should be familiar with the types of norms that exist. So I listed them here. So descriptive norms are really about what I think other people do. So if I think everyone in my social surrounding drinks 2 glasses of alcohol per day, then that is considered for me as normal behavior. And then I'm more likely to also drink 2 glasses of alcohol per day, because that is what I think other people also do. Then you have injunctive norms, and those are really related to what I think other people will approve of or disapprove of me doing. So if there is a general social norm of you shouldn't drink alcohol, then if I drink alcohol, I will feel that other people will disapprove of me doing so. So that will inhibit my feeling or my desire to drink alcohol. And then there are subjective norms, which is really a term used in health models that you've also been talking about with Anna, like the theory of planned behavior. And those are the norms that are communicated either explicitly or implicitly by significant people in my social environments, and how I think they expect me to behave. So if I think that the general injunctive norm of not drinking alcohol is also very much adhered to and appreciated by my significant others in my close social networks, then I also think that these people expect me not to drink alcohol. So the subjective norm is don't drink alcohol because they will disapprove, so I won't drink alcohol then, or at least the likelihood of me drinking alcohol is reduced greatly. So norms then predict our intention or decision to perform a certain behavior, which in turn, of course, influences our behavior. And I'm sure that Anna and your other lecturers also already discussed with you that intention and behavior, it seems like this is a very clear relationship, but there's a lot happening here that isn't explained in a lot of models on health and health psychology and health behaviors, because we have a very clear intention behavior gap. Even if I want to quit smoking, the likelihood of me actually quitting is not very high, because there are other processes playing a role on the relationship between intentions and behavior. So what we do is we obtain these normative and behavioral guidances on how we should behave by comparing ourselves with other people. And I want to briefly go into social comparison because it is so central to all kinds of social influences, because we are less likely to be influenced by people that we don't compare ourselves with. And we don't compare ourselves to people who we think aren't relevant comparison standards. So what we do is we compare ourselves to others who are similar to us and people who are close to us. And people who are similar and close to us are most likely to be peers. So people of my age, people of my my age group, my generation, people who are in the same circumstances as I am. So I have teenage children. My oldest son is 14 and my youngest two children are 12. So my peers would be also people who are mid-40s and who also have teenagers at home. So because those people are most relevant for me to see how should I behave in a certain situation, and is it normal for me to punish my children or to tell my children not to spend so much time playing Fortnite. And if I want to know whether that's normal and an accepted behavior towards my children, I look at other parents of teenage children that play a lot of Fortnite to see how do they behave, how do they interact with their children. So what I also want to stress is that peers are often, if you talk about social influence and the influence of peers on our social and health behaviors, what you usually think about is peer pressure. So this negative influence that other people have on our behaviors, and that is really, peer pressure is really closely related to the normative social influence that I already mentioned, and you see that a lot among teenagers. So peer pressure exists in the context of starting behaviors like smoking or alcohol use, where you see that young people are very much influenced by what their friends do, but also what they think they need to do to be accepted by their friends. But peers can also have very positive influences on our health. So the influence of peers can be damaging or encouraging in terms of our health behaviors. So then we have types of social influence on our health that I want to discuss. And there are 4 types that I want to go over. There is social facilitation, modeling, impression management, and norms. And of course, I already briefly touched upon a few of these. And this is really core social psychology. And that is also what I like about social psychology, but also about talking about health and health behaviors and psychology, and that you can see that a lot of the processes that we have identified in the context of social psychology, developmental psychology, are really also at play if we talk about health and health behavior and health psychology. So first, social facilitation. And as you may remember from your introductory course on social psychology, social facilitation really is the fact that the mere presence of other people, so being in an audience, for me, for example, I know that it's about 170 people looking at me, listening to me, that makes me either perform very well or very poorly. And the difference between me doing something very well in this context versus me doing very poorly depends on how often I've already given a lecture, for example. But the core of social facilitation is that just presence of other people influences how we behave. And this happens outside of our awareness. And I think one of the nice studies that I can show you, go back, is about the speed and the amount of snacks and lunches consumed by children when they are in a larger versus a smaller group. So they did this study in elementary schools, in kindergartens, where children during lunch breaks eat lunch in the presence of other people, so other young kids. And what they noticed was they kept track of how fast these children ate, and also how much they ate in like 20 minutes time that they got to eat their lunch. And what these researchers noticed is that as soon as these kids were in a large group, like nine children aged 4 to 6, they ate both a lot more, but also a lot faster than when they were in a smaller group of only 3 people. And you also see this in, you probably have noticed in your own experience that if you eat only with one person, you probably eat less, and you also take more time to eat than when you're in a large group of people and you have like a dinner with 15 other people. It also, you don't seem to notice how much you eat at that time, but also not how fast you eat. But this is a pattern that's been found among adults, but also among children, and nothing changed in these two conditions except the number of children that were present while they were eating their lunch. The social facilitation also has a big influence on risk taking, and sorry for the male audience members, but this is really especially an influence that males, men, young boys are susceptible to. What you see a lot is that as soon as men are in the presence of other men, the risks they take, so the physical risks they take, increases exponentially. There's even evidence that if you are driving in a car and there is a male passenger, just another male passenger, you double your chance of dying per 1,000 car crashes. So just the fact that there's a man in a car already increases your chances of dying. The likely explanation for this is that for men, risk-taking demonstrates their ability to belong to a certain in-group. They want to win admiration and praise from their peers by doing extreme, risky behavioral things. They want to be accepted into a certain peer group, and they want to show that they are actually worthy of being accepted. Of course, these are extreme examples, but I think if you've ever spent a few hours on YouTube, these movies, these movie clips, you don't see them so much for females. Females are just generally less likely to take risks on all kinds of health-related dimensions, by the way. So the second basic and core influence on our behavior is modeling. And Bandura, a famous social psychologist, already established how modeling has a strong and pervasive influence on our behavior in 1977. And he says, just by seeing other people behave in a certain way shapes our own behavior, because we sort of form beliefs and attitudes about the reasons that person is doing that behavior. And that is internalized, and those are actually transformed or generalized to our behavior. And modeling can take very explicit forms, which I will show you in a bit, but it can also take very implicit forms. And one of the most implicit instances of modeling is behavioral mimicry. And if you've ever, you probably are familiar with social psychological processes, but mimicry happens if people like each other. So mimicry is a good sign of having a very what they call interpersonal rapport. So if you notice yourself taking on the same physical or nonverbal gestures, or you sit, if I would sit like this with my arms crossed, and I see at some point that the people sitting across from me also take that same body posture, then I know that they like me. And then that increases interpersonal liking, and also the likelihood that I can actually persuade them to maybe offer me a job, or but the likelihood of me having more social influence if I see mimicry happening is very large. You can also see it in situations where people are dating each other. So people who are, there's a television program, I don't know if you also have something like that in Indonesia. In the Netherlands, it's called First Dates, where they film individuals who go on a blind date with each other. And they just have dinner, and that is, the interaction is filmed, and you just see two people having dinner and interacting. And then afterwards they're asked, so would you like to have a second date with this person? And as soon as you see that these people have same body postures, or they lean into each other, then you can already estimate, okay, that will be a second date. Or if you really see that they don't mimic each other at all, you also know, okay, there won't be a second date. So mimicry also happens in the context of health behaviors. And there's a study by a Dutch researcher, Hermans. They actually investigated taking bites of sandwiches, and how much mimicry there was. And that is also related to liking. But what you can see here is that these instances where I've circled, those are high mimicry diets. So this shows that as soon as one person takes a bite, the other person also takes a bite. So if you are the one sort of guiding the interaction, you can also steer people towards more healthy behaviors by either taking a lot of bites, or by not taking bites anymore. So they also studied, or actually investigated, modeling behavior by just pretending that someone either ate a lot or not a lot of food, and showing like a plate left, a plate of food left by a previous participant to a new participant. And just the fact, for example, that if participants saw that the previous participant only ate 50 grams of candy, they also would not eat more than that amount. Whereas if the previous participant had eaten a lot of candy, they would also increase their own eating behavior. And of course, the most famous example of mimicry that Bandura established is the Bobo doll experiment. So you can see this blow-up doll. This is Bobo. This is the famous Bobo doll. And Bandura really established the practice what you preach concept, mimicry and modeling. And he showed that the way adults, in this case the parents of these children, the way they interacted with Bobo, whether they were friendly or very aggressive towards him, influenced how their children subsequently also interact with Bobo. And this little girl, if this research indeed shows what Bandura thought, and it did, this little girl previously saw her father or mother also beating up Bobo, and she's now doing the same thing. So this is also really relevant in the context of health behavior. If I want my kids to eat healthy, I have to give the right example. I can't be eating chocolate all day and expect my children to only eat fruits and vegetables, for example. I have to give a good example because that is what my children learn from. And what you also see, and here the influence of social media starts to appear, is the influence of unhealthy behaviors seen in other people. So the modeling of unhealthy behaviors, and smoking or vaping is one of the behaviors that especially youth are very susceptible to. Smoking is still considered cool, whether it's vaping or smoking weed or just regular nicotine. But if you smoke as a parent, your children are 6 times more likely to also smoke. And what you also see is that celebrity endorsers on Instagram, smoking or vaping also increased the number of positive associations that individuals and especially young people had with vaping, but also increased actual sales of vaping devices. And as soon as this became knowledgeable, and also what we know now is that vaping isn't as harmless as initially thought. As soon as this became a thing, these celebrities also made sure not to be seen vaping in public anymore. But as soon as a new behavior emerges, you see celebrities and social influencers doing the behavior, which then, as sort of like this, you know how it works with social media. It's like this oil stain. It generalizes across the population, and the behavior becomes more common. And it's good if that is a positive behavior, but it's negative if that is a negative behavior, like vaping. So peers also have an influence on our levels of physical activity through modeling and socialization processes. If you happen to be friends with a group that is very much into physical activity, you're also more likely to be physically active. But also keep in mind that there are social selection processes happening there. You also tend to choose peers and friends and social networks based on your interests. So you're more likely to have physically active friends if you already have an inherent interest in physical activity. So similar adolescence, that's again the social comparison process. You select people who are similar to you in terms of interests and attitudes, and those then also have a larger influence on our social behavior. But since we know that peers can have a very positive and very strong influence on our health, what you also see is that there is an increase in the use of peer educators in health education and health promotion programs. And especially for sensitive topics, like, for example, sexual health education, it works often better to use peer education than to have adults telling young people why you should have safe sex, or why certain risk behaviors are a bad idea. So what you see, especially in the context of health risk behaviors that are also very much under the influence of social appreciation or social evaluation, if you actually use a peer educator, you can achieve more health behavior change. So these are 10 reasons why peer education could be a very viable, cheap way to engage in health promotion and health education efforts. Because, as I said, they're positive role models, they're more acceptable than maybe adults trying to actually tell you something. Also, one positive thing is that peers can reinforce learning, because these peer educators are often also people you keep on meeting in school, for example. So adult educators are people outside of your social sphere, so to say. So there are lots of reasons why peer education is maybe a cost-effective and positive way. So the third basic social influence on our health and health behaviors is impression management. And those can be defined as all the attempts we have to consciously or unconsciously control the impressions other people form of us. And we do this by regulating the type of information we provide to these people, and we do this by strategic self-presentation. And as you may already guess, social media is, and especially Instagram, so visual based social media is a very it's one of the platforms that we see impression management the most. And what you also see is that in the past few years, luckily, there is a lot of knowledge about the fact that a lot of people on Instagram use impression management, because it used to be the case that for a long time, of course, especially if you're young and you're new to social media, and you don't know that the pictures or the image presented to you on social media may not be the actual real life representation of these individuals' lives. And these are a few of the examples that you see nowadays, where influencers try to correct the impression management that they engage in, but especially that other people engage in. And this is one of the social influences that you can see, that this, just the way you sit and how you pose influences what your body looks like. And of course, some of the filters that Instagram actually used are now banned. There was this one filter called Plastics, which was actually, it allowed you to see how you would look after cosmetic surgery. This has been banned after social pressure from a lot of different groups, because it really gave a wrong image about, it suggested that you should have plastic surgery, for example, to be able to look good enough. So there's more attention for the way people use impression management on Instagram, which is good. So there's a body positive movement, but also influencers like these are very much able to show, look, the picture you see isn't necessarily the truth. But impression management goes further than just influencing how we think about our bodies or how we think about how we should be, because it also actively inhibits healthy behavior or promotes unhealthy behavior. And again, these types of influences are more likely to exist in the context of behaviors that are considered sensitive or socially sensitive. For example, it's still the case that a lot of young people still do not want to be seen buying condoms or the morning after pill, because they are afraid of being seen as promiscuous. So 62% of young people report feeling embarrassed in engaging in health protective behaviors, for example. What you also see a lot is that individuals still engage in having artificial sun tanning. So what you see as well is that people just want to look good and appear healthy, and therefore do not use sunscreen because that makes them have a brown skin faster. So smoking, for example, is also used as impression management. A lot of students that I talk to and I ask, so who smokes? At first, everyone says, no, I don't smoke. But then if you start to ask, but you never smoke, so also on the weekend, you never smoke, then they sometimes say, yeah, no, but I smoke. I'm smoke in social gatherings. So yeah, if I go out and we have a drink, then I'll smoke. So this presenting yourself as an occasional or social smoker makes people feel immune to the health risks of smoking, even though, of course, they're still smokers, but they still inhale all the negative elements of cigarettes, even though they don't feel like a regular smoker. So impression management can also have detrimental effects on our health, and especially in the context of alcohol. So alcohol use is very much a behavior that is influenced by impression management principles. You want to fit in, you don't want to look like the sissy who doesn't drink. Um, if you go out with a group of peers who are very popular and you know they have a high status in the social group that you're also a part of, and you want to fit in with that group, then alcohol use is more likely to be engaged in, and also extreme alcohol use, of course. Student populations, I don't know how it is in Indonesia, but it's probably also due to religious reasons, maybe less of a problem where you are. But here in the Netherlands, we still have big problems with binge drinking, especially during the time of the year when new students are initiated into student associations. What you see is that people engage in extreme binge drinking. So they drink more than 5 glasses of alcohol in one sitting, in one evening, and they do this for a number of evenings every week. And sometimes it's not beer, but it's strong liquor. And we still also every year have cases of alcohol intoxication and hospitalizations because of alcohol use. And this is all stimulated by impression management, wanting to be accepted in a certain group. So peers provide strong normative context. They also provide you with the normal behavior in a specific social context. So norms influence our behavior, especially peer norms. They influence our behavior. But then how do we know what the norm is? And if we think we know what the norm is this knowledge accurate? And there's a Thomas theorem that says that even though these perceptions of reality may not seem real, if we think these are real situations and our perceptions of these situations are real, then the consequences of these perceptions are also real. So if a person perceives a situation as real, it is real in its consequences. So what is really important for health promotion experts and psychologists is to correct misperceptions, because we often have misperceptions about other people's attitudes, so peer injunctive norms, or other people's behaviors, which are called peer descriptive norms, which in turn influence our own behavior. And this is also the case for health risk behaviors, for example, alcohol use. And what you see a lot, especially in universities and colleges in the USA, is that there are very extensive attempts to correct these misperceptions. Because if you think it's normal to drink, to drink the 2 glasses of alcohol, because you think everyone does it, then you will actually be guided by that perception of the norms in your social environment. And it may be good to realize that actually not every student drinks alcohol every day. So this is one example of this health promotion or health education communication, where they actually, from Dexter University, say 7 out of 10 Dexter students do not drink alcohol. So these are efforts to provide a correction of a misperception to hopefully change problematic behavior. So this is actually, I don't know, Anna, if we can have a small break here to just have some coffee and to go to the toilet for the participants.
Yes, of course.
Yeah.
So this is the end of part 1, and after that we will discuss about the social determinants of health. Maybe we'd like to have like 10 minutes of break.
Yeah, that sounds good.
Yeah. So we have the questions after everything done. So
yeah,
good.
Yeah, we can also have the questions after the break, or we have questions about this part now and then have a break. I'm also fine with that.
Okay. Okay, it's okay. Now we have 10 minutes break, and then after that we continue at 3:38 then.
Yeah. Okay.
Good.
See you in a bit.
Yep.
Dear Diary, today I got an A after studying for 2 hours.
I think we still have 1 minute left for break. Already. Do you have your coffee?
Yes.
It's quite cold over there, right?
Yeah, it's mainly gray. It's just very I think it's now how many degrees? Yeah, about 2 or 3 degrees Celsius. So it's cold, but it's December, so that's okay.
Yeah, that's okay. And then you will have snow in the near time, right?
Maybe.
Probably.
There's not a lot of snow anymore due to
Yeah.
climate change, and but there was one meteorologist who said it will be a colder white winter, maybe.
Okay. I think you are in your office now at your room.
Yep.
Yeah.
Yeah, the Wi-Fi is a bit more stable here.
Yeah.
And my oldest son is at home because of there are a lot of teachers who are ill or quarantined, so he has to have homeschooling.
Because we heard that COVID's already like having bigger effect in Europe nowadays.
Yeah, it's strange because we have a lot of vaccinations, but it's never been as bad as it is now.
Yeah.
So
Yeah.
It's an ongoing issue, which you probably also
yeah, we are also prepared, but yeah, hopefully it's not as bad as the second waves before.
So are schools open again or not yet?
Not yet, but we are preparing for that.
Okay.
Okay, so now we are going back to the lecture before So, dear students, before we continue to the second part of the lecture, I would like to resume what Dr. Karlijn already explained to us. I feel that this lecture is enlightening because it's like few years ago I'm listening about this kind of lecture, and still as interesting as it is, because I feel that learning about social influence in our behavior is quite interesting, since it is mainly affected our own behavior, including our behavior. We can find it or feel it or even perform it ourselves in our very everyday lives. And maybe we also see that our friend also performed something like Karlijn already told us. For examples, Dr. Karlijn talked about social ties. So we feel now that we understand that network sites, both the quality and also the quantity, will promote better physical and mental health. And now we feel that when we are in a pandemic situations, that we cannot see many people, many of our friends, that it's feel lonely and something like that, because it's not normal due to our past normal life, but this is new normal then, that we are away from our friends, but still we still feel the emptiness maybe, or feel a little bit stressed about that. And also Dr. Karlijn explained about type of social influence. We understand about social facilitations, that the presence of other people will influence our behavior. For example, how we eat, that whether this is a small amount or a large amount of food that we consume is largely depend on who our companions. For example, maybe if we are eating with our boyfriend, for example, and you need to perform as a very beautiful lady that usually only eat small amount of food, but you press yourself not eat a large amount of food. So it's really depend on who are you with now, that it will interfere with your behavior. And also modeling, that we see how our other people behaves, and we will also behave in a certain behavior, also the same behavior as other people performs. And also impression management, and usually it's quite interesting about the Instagram pictures you show about the cat. Usually we put the beautiful picture as the profile picture in Instagram and also Facebook and everything, but this is our efforts to impress other people. This is the evidence of impression management. And also norms, if it is perceived as real, then it is real, and the consequences is real. Quite interesting. So before we continue, student, whether you have any question or anything that you like to discuss with Karlijn, you can raise your hands, and then you can speak directly. Also in Indonesian, I will translate it for you. Or you can also write in the chat box whether anyone like to discuss about social influence in a behavior and also health behaviors. Not specifically have to be a health behavior, but our behavior. Kalau misalnya ada yang kalau misalnya ada yang mau nanya dengan berbahasa Indonesia, silakan. Nanti saya akan menerjemahkan untuk teman-teman. Apakah ada yang nanya? You are so quiet.
Maybe they're shy. But I'm very friendly, so don't be afraid to ask me anything. And there are no stupid questions either.
It's very friendly. No question for now?
Well, then I can also continue and maybe
it's okay if you have any question during the second part of the lecture. You can write down first, or maybe you can also write down in the chat box, and then later we will answer it in the last sessions. Okay.
definitely.
So, kalau teman-teman punya pertanyaan, silakan dituliskan di chat box, nanti kami akan menjawabnya. Saya akan mentranslatekan dan dijawab oleh Karlijn di akhir sesi yang terakhir, begitu ya. So maybe for now, Karlijn could continue her lecture in the second part of the study of the lecture about social determinants of health.
Yeah,
it's yours, Karlijn.
Thank you very much. Yeah, so the social determinants of health are really about the structural factors and are really about more simply said where you are born, the country you are born in, the opportunities that you have or the restrictions that are there in your the country or the community that you are born into. And social determinants of health are really about your social and community context, but also whether there's economic stability in your direct environment, whether you have education access, but also what the quality of the education is, whether you have healthcare access and what the quality of the healthcare in your country is, and also the neighborhood you are living in, and how much, for example, the built environment, that is meant with how many buildings and the density of the population. So the social determinants of health are really defined by the World Health Organization as the conditions in which people are born, grow, work, live, and age, and a wider set of forces and systems shaping the conditions of daily life. These forces and systems include economic policies and systems, development agendas, social norms, social policies, and political systems. And as you can see, excuse me, this to a large extent seems like this is something that health experts, behavior change experts, social psychologists, and health psychologists really cannot intervene on or have any influence on. But you can also see that they already mention social norms explicitly here in this definition of what social determinants of health are. So the social determinants of health are the conditions in which you are born, grow, work, and live. These lead to differences between groups of people. And they can lead to unstable housing, low income, unsafe neighborhoods, or substandard education. And this creates inequities between groups of individuals. And simply said, it depending on where you are born, in which country you are born, but also in which area of the country you are born, really determines to a large extent how long you will live, for example, how many years in good health you have, but also whether you have access to education, whether you have a economic stable life. And depending on where you are born, you can be either well off or not so well off. So it leads to inequities. And interestingly enough, there for a large time, once healthcare, especially in Western European countries and in the USA, once healthcare started to really take flight and really have a lot of improvements, the idea existed that as long as healthcare was okay and available to a lot of people, or ideally the majority of the country's population, then the differences between individuals from a lower or a social or higher social class, as they were then still referred to, would be resolved ultimately. So this socialist idea of providing everyone with good healthcare and basic income would eliminate differences between individuals. Well, in recent years, what we have discovered as researchers and as social scientists is that over 50% of our health and our health outcomes are determined by social and structural factors. So as you can see here, only 30% of everything that makes up our health and our health outcomes is determined by what we do, the behaviors we actually engage in, like tobacco and alcohol use, nutrition and exercise, sexual activities. But only 20% is actually influenced by access to care and the quality of the care what we can expect. And over 50% is determined by the socioeconomic factors that we are born into and the physical environment that we live in. And essentially 50% can be traced back to your zip code. And that is also the way that a lot of research is being conducted. If we want to study the differences between people with a lower and a higher socioeconomic position, we also here in the Netherlands tend to look at zip code, so postcode. And there are large differences in the healthcare costs that people have, health outcomes, years living in living healthy lives. For example, in the south of the Netherlands, where I live, this province is one of the provinces in the country with the biggest socioeconomic gradient, meaning that there are people more towards the east of the province here and south of the country who live on average 6 years shorter than people from other areas of the province. So 6 years, that's quite a big gap. And they also have less healthy lives. They have more healthcare costs. So even in a very industrialized Western country, the socioeconomic gradient is present and affects our health. And this is actually a graph from the USA, from data from 2006. And I'm including this to illustrate that these health disparities and the fact that there is a difference in life expectancy based on, in this case, your education and gender, that these differences exist not only in countries that are classified as lower middle income or developing countries, but that they also exist in developed countries or weird countries. And weird is an acronym that stands for Western, highly educated, industrialized, rich, and democratic countries. And of course, the USA and the Netherlands are a weird country in that sense. But what you see here, for example, is that men in the USA in 2006, but I don't expect that this will be, maybe the age expectancy is higher in all these groups, but the difference probably won't have changed. But what you can see is that individuals with a lower education, so in this case, men with less than high school, they live on average about 9 to 8 years shorter than men who have a college degree. And the difference is here for women as well. It's slightly, women on average live longer. That's the case in every country. The difference is present for females as well. So if you're a lower or a higher educated woman, you live longer than when you have a lower education. So these data are actually, I mean, you can make these graphs for every country probably in the world. So the idea is, what then is the explanation behind these differences? Why is it the case that things like education or income make such a big difference on health outcomes and mortality and morbidity? Well, WHO has also defined 6 specific types of social determinants on our health. So these are the social gradient, which is simply said the difference between individuals with a lower and a higher social economic position. And then there is the influence of stress, early life circumstances, social exclusion, work or unemployment, social support, addiction, food, and transport. So these are social determinants that are essentially, as you could see in the definition, the social conditions in which we live and grow and work. But what we can also, of course, already think about and discuss is that those socioeconomic disadvantages from society, those structural determinants of health, are really difficult and maybe even impossible to eliminate from society. So the one of the solutions for some of these social determinants and how they explain health inequities would be, for example, to give everyone a basic income, to make sure that everyone has access to education and employment, that there is no social exclusion based on gender or ethnicity or age. But that isn't, that's possible, but not at the level of work that we and you also will be working at. So social psychologists, health psychologists, and behavior change experts are not able probably to eliminate those socioeconomic disadvantages. So what you could do then is to target, first identify, but then target intermediary factors that explain why, for example, educational attainment is related to health. And what you can see here in this model by Braveman and colleagues is that they identified several intermediary factors that could explain why a certain educational attainment level is related to a certain health outcome. And here they talk about health knowledge, literacy, and behaviors, especially about nutrition, exercise, health risk-related behaviors, but also health and disease management. And Anna can probably also tell you a lot more about this, because she's also, her project was about health knowledge, specifically, because Anna did research on breast self-examination to prevent early or to prevent breast cancer, but to actually increase early presentation with breast cancer in healthcare. And as you also, I don't know, did you already give a lecture, Anna, about your own research to the students?
Yes.
No?
Yeah.
But what we also discussed also during your PhD defense is the role of knowledge and literacy, and that, I mean, it isn't the only explanatory factor, but it is relevant to know about certain health risks, to know about certain health protective behaviors in order to actually engage in these behaviors. And that, especially for in your project, was about, of course, the health management and screening behaviors. So this is an important intermediary factor that, well, Anna wrote her whole dissertation about this, and she can tell you much more about it than I can. But this is one of the intermediary factors that social psychologists and health psychologists can actually work on. One other area is about work and income related issues, and those are maybe more of a area for work and organizational psychologists. But on the other hand, I will also show you at the end or towards the end of the lecture about the project that I actually worked on about increasing lifestyle behaviors among lower socioeconomic position employees. But these are about, I mean, working conditions can also range very much. I mean, my work is behind a laptop. It's very safe. I'm not exposed to any hazards in my environment. I have good health insurance and sick leave regulations. But if I would work as a cleaning staff, I would be exposed to much more physical strain, repetitive movements, but also maybe toxic fluids that I can inhale, or so the working conditions can also influence your health outcomes, in the sense that you may have a physically demanding job versus a physically undemanding job. On the other hand, a job like mine can also be very unhealthy because of the nature of sitting down all day. And then there's these more social and psychological processes that are really interesting to me. And of course, I already talked about social supports for a bit. that are really influential in also influencing health-related behaviors. But this sense of control is also really important, and that will also come back in the intervention that I will talk about in a bit, because having a sense of control over your life, especially when it comes to health, but also when it comes to your work, really influences how you engage in health-related behaviors, health protective behaviors. But this is one model that also, that explains how there are intermediary factors explaining why a lower educational attainment is related to certain health outcomes. And this is the model that WHO itself actually developed. And here they placed the structural determinants of health. You can see there's a big influence, causal influence, of course, is from the socioeconomic and political context, all kinds of social policies, governance, public policies, but also culture and societal value systems that are in place. And that, of course, that differ a lot depending on where you are born. And then structural determinants, these political and socioeconomic contexts, they feed into where you are born into in the sense of your socioeconomic position and your social class, which in turn is highly related to gender and ethnicity. And also these factors, they are structural determinants of health, but they are also to a large extent the reasons why some groups in society are exposed to more or less favorable circumstances than other groups in society. You can also see that they place racism here in where they mention ethnicity, which of course is a big issue if you are a minority group in a majority. What you can also see is that these elements of socioeconomic position and social class, they influence the structural determinants. So it's sort of this bidirectional nature, but they also influence how your educational trajectory is formed and how then after your education you can get into a certain occupation and obtain a certain income. And what you I think what isn't really maybe as explicitly identified here, but what is implicitly present is this sort of feedback loop and this idea that as soon as you are in a certain socioeconomic position, you are exposed to certain socioeconomic and political context, it's really hard to escape that loop that you're part of. But what is also interesting here, WHO also identified a good set of intermediary determinants of health. Of course, one of them is the health system, but as you can see, as I also tried to already explain, is that the health system is really separate from these intermediary factors and determinants of health, in the sense that the health system is important to ultimately maybe help reduce health inequities. But at the same time, it is only a small percentage of everything that makes up our health and well-being. And these elements like social cohesion and social capital, behaviors and biological factors, psychosocial factors, material circumstances, those have a much larger effect on equity in health and well-being. And especially the psychosocial factors, that is what I will zoom in on now, because those are the elements that we as experts, behavior change and health psychology experts, were most likely to be able to intervene in, but also most successful. So one of the most interesting models that I've been exposed to, or that I've encountered over the past years, is the reserve capacity model by Galloway and Matthews. I didn't finish this reference, I see, but it's 2003. And this is really a model that explains the pathways between socioeconomic position on the one hand and disease states or health outcomes and health behaviors on the other hand. And what the reserve capacity model says is that the impact of your socioeconomic position on your biobehavioral pathways and disease states, so health outcomes, is on the one hand direct. So there are direct influences on being born into a certain circumstance, but it is also mediated to a large extent by psychosocial resources. And these psychosocial resources in turn also moderate the relationship between socioeconomic position, stress, and negative emotions and distress. I will go into these in more detail. So stress is identified as something that is really impactful. And as you can see, one of the closest consequences, or the most proximate consequences of socioeconomic position, is the fact that people from a lower socioeconomic position are more likely to experience more daily stressors, daily hassles, but also more traumatic and life events, more chronic stress, and also they have higher perceived stress. So what this means is that individuals with a lower socioeconomic position, also purely due to the fact that they are born into certain circumstances, they probably also have more financial strains, more worries about finances and how to get by, how to feed their family, for example. But interestingly enough, due to the fact that they are born into a stressful situation, and especially what is relevant if you talk about what evokes stress or how people think about a certain context as stressful, is unpredictability and harshness. So if you are born into a context that is very unpredictable, in the sense that you don't know from one day to the next whether you will have sufficient finances and food, or you don't know from one day to the next whether there will be conflict in your immediate surroundings, so psychological conflict or not, you start to feel very psychologically unsafe and very stressed. And what research has also shown is that individuals with a lower socioeconomic position are also more likely to see certain events as stressful and distressing than individuals with a higher socioeconomic position. So the same event could happen to someone with a higher socioeconomic position who would think about it in terms of, yeah, it's annoying or it's inconvenient, whereas someone with a lower socioeconomic position would have the same event and see that as very stressful and distressing. So what you also see is that socioeconomic position and stress are related inversely to psychological distress and anxiety and depression, but also to certain emotions like anger or sadness. So this is this pathway. So if you're in a lower socioeconomic position, you experience more stress, more adversity, more unpredictability, more harshness, and this in turn leads you to experience more negative emotions and also more psychological distress. And the psychological distress is the negative consequences of having a certain daily context like anxiety and depression, but they are also emotions like anger or sadness, and also those in turn, of course, also determine how we are engaged with by other people. So what the reserve capacity model also states that over time, this is an important factor as well, over time, this repeated exposure to stress, the repeated negative emotions and negative cognitive patterns that people engage in, they create this wear and tear from repeated psychological stress responses They are often combined with unhealthy behavioral coping strategies. And over time, those processes take a toll, increasing their vulnerability to disease. Because what we also know, of course, from physiological research is that chronic physiological stress responses are very negative for your immune system. And individuals who are exposed to or who have an overactive physiological stress response for a prolonged period of time, they are more likely to suffer or become vulnerable to certain diseases like cancer, but also, of course, physical or mental diseases. So it's not necessarily that you become less healthy because you're in a certain socioeconomic position, but there are all these intermediary factors coupled with prolonged exposure, because as I also showed you, there's this loop that a lot of people are unable to escape from, that creates this vulnerability to disease. So this is how stress would be functioning in the relationship between SEP and health. So what you can also see in research by Gallo is they actually looked at daily variations and fluctuations in people's emotions and how they perceive to have control over their lives, and whether they experience any social strain. So they these are I think are data from women only, but they actually had people report on these dimensions for a number of days. And they had 3 groups of women. So they had groups of lower, medium, and higher socioeconomic position. And they just let them fill out, like on their smartphone, a few days, how much they experienced control over their lives, whether they experienced any positive effect, or whether they experience any social strain. And as you can see here as well, individuals with a lower socioeconomic position both had less control beliefs, less positive effects, and more social strains in their daily lives. So this also exemplifies the relationship that this model actually tries to prove, the fact that it's not only the basic socioeconomic circumstances that you're born into that create this stress, but it's also the daily repeated interactions, the daily experiences of certain cognitions, but also social interactions and emotions that explain why, or that illustrates how socioeconomic position is also related to certain appraisals of social context, but also just pure factual experiences. And as you can see here, these control beliefs are really important. They have a very large effect on how people feel and how they perform. And they are also central to the intervention that I will show you in a bit. So this is actually work by Gallo and Matthews on this specific reserve capacity model, and the role of negative emotions. And I mean, I really like this model because it really, I have only focused on the negative so far. But what the reserve capacity model is named after, and what it actually focuses on, of course, is psychological and social resources. So these reserves, or the reserve capacity, that the model really is named after, are interpersonal and intrapersonal resources that by Gallo and Matthews are seen as sort of a bank of resources that people can use to be resilient or to buffer against the adverse consequences of having a lower socioeconomic position, for example. And they identify 3 types of resources. So they have tangible, interpersonal, and intrapersonal psychological and social resources. And what they mean with this is that tangible resources are really things like, do you have access to and can make use of infrastructure? For example, is there, if you need to get to school or to your job, can you use public transport, or do you have transport yourself? So basic infrastructure. Do you have sufficient money? So financial resources to rely on in terms of or in times of stress and adversity, but also interpersonal resources like social support. So do you have a social network that you can rely on to help you with emotional, but also instrumental support if you need it? Intrapersonal resources are the elements that psychologists focus on, and in our case, the psychological processes or abilities that people have, including emotions, by the way. For example, self-esteem, but also coping mechanisms. And in the case, I'm going to focus on that in a bit. In my research, I focus on psychological capital a lot. But what is known and what is actually established time and time again in research is that individuals with a lower socioeconomic position tend to have lower reserve capacity. So they tend to have a less big bank or resource capacity to fall back on in times of need. So what you see is that individuals with a higher socioeconomic position, they have more money, so they also have more possibilities to have tangible resources to their disposal. But they also often have larger, more supportive social networks. They often have increased intrapersonal resources to their disposal. So what you also see is that lower socioeconomic position individuals are less likely to have a reserve capacity because of purely the exposure to more situations over their life course that require use of these resources, but also because their environments prevent the development and replenishment of these resources so they can keep them in reserve. And this is really essential also to keep in mind, that it's not just, I'm going back to this model again because it explains a lot. It's not just where you are born into, but it's also this loop that you cannot escape, you know, what I also talked about here. If you are born into a lower socioeconomic position, there is a very large likelihood that you will, over the course of your life, even over the course of a week, just are exposed to much more stressful, negative situations. And as Galloway and Matthews state, this makes it less likely that you can both build up a reserve of these interpersonal and intrapersonal reserves, but also that you need to use more of these psychological reserves to just cope with everyday challenges and stressors. So these two elements explain why individuals with a lower socioeconomic position are less likely to have a reserve capacity to their disposal, and why individuals with a higher socioeconomic positions do. Then there's a element of time, which I also showed you in the model, and that is related to the life course perspective that the reserve capacity model also takes. And in that sense, that is closely related to the research I do, and the perspective that I tend to take in my research about how evolutionary psychological processes are relevant to explain or are still present in our daily environments at a very implicit level. But they explain how being born into a certain situation can sort of turn on certain cognitive, physiological, psychosocial processes that then have an effect throughout the rest of your life. So childhood socioeconomic position, for example, and an adverse early family environment, they are associated with poor psychosocial adult functioning, so more negative emotions, less coping or less adaptive coping mechanisms, and these in turn are associated with poor metabolic functioning. So what research, especially also by Galloway and Matthews, but also a lot of other researchers has shown is that the environment you grow up in as a child, especially the first 1,000 days, but also maybe between your birth and age. Some researchers say it's between 0 and 5 that is the most relevant sort of imprinting phase. Others say no, it's the time until you're 12 that is really relevant and makes you adopt a certain life strategy and perspective. But what I used in my own research is, I think, childhood. So thinking back to your life around or between when you were about 0 and 10 years old. And I used a measure of relative childhood socioeconomic position where we asked our participants to indicate when they were growing up, whether they felt like they were better off or worse off than others, whether they felt like they always had sufficient money or resources to do nice things. So it's this relative position relative to other people in your surroundings. But what is really important in explaining how these early family environment and childhood socioeconomic positions influence later life health and health behavior is, again, as I already said, the harshness and the unpredictability that is often associated with those adverse environments. So neglectful parenting, lots of conflicts in your direct environment, divorce at an early age associated or accompanied by a lot of fighting, stress amongst your parents because they felt like they didn't know whether they would have money or food to their disposal and to feed their families. And this sort of triggers this whole cognitive and psychosocial trajectory of having more negative appraisals of certain stressful situations, being exposed to more stressful situations, having less adaptive coping mechanisms to deal with stressful situations. For example, starting to use alcohol rather than try to solve the problem. And what we find in our own research related to these reserve capacities that individuals also have is that psychological capital is really an important variable that buffers against the adverse effects of lower childhood, but also adult socioeconomic position. And I will explain more about what psychological capital is in a bit. So PsyCap is really a higher order psychological construct that is made up of 4 distinct psychological dimensions or elements. And this is the traditional definition provided by the developers of this PsyCap idea, especially Fred Luthans. So PsyCap is an individual's positive psychological state of development, characterized by having the confidence and skills to take on and put in the necessary effort to succeed at challenging tasks, so efficacy, making positive attributions about succeeding now and in the future, which is optimism, persevering towards goals and, when necessary, redirecting paths to goals in order to succeed, hope, and last but not least, when beset by problems and adversity, being able to sustain and bounce back and even beyond to attain success, which is resiliency. So there are 4 distinct psychological processes cognitive abilities, but also more emotional elements that make up a higher order construct we call PsyCap. So PsyCap consists of hope, efficacy, optimism, and resilience, where hope and optimism are more emotional states that are, if you have more hope and optimism, you have different appraisals of certain situations, but optimism and hope, especially, what they do is they reinforce future-oriented thinking, which I will also explain in a bit, which is really relevant and which is really also something that individuals with a lower socioeconomic position tend to lack. But then you can have hope and optimism that you can achieve certain goals, but then you also need to have the confidence to know that you can rely on your own abilities to achieve this goal, and also resilience in the face of stress and adversity, and know that you can overcome these obstacles, being able to recuperate and go on again. So PsyCap was originally developed in the context of organizational psychology, because these are all organizational psychologists. And what they actually noticed is that if you increase PsyCap in your employees, you can actually make them, or their performance is increased. They do better at what they are supposed to do. They report increased well-being at work, so they like their jobs more, which in turn also, of course, positively influences their performance. And what I and my colleague Karen Offermans have done is really try to use the construct of PsyCap in health-related research and health-related behaviors, because there is such a thing as health-related PsyCap, but it has been neglected a bit. At least that's my personal opinion. And PsyCap is more the focus of increasing performance and make people get the best out of their lives in the organization that they work for. So what I also wanted to tell you about, because that is really why PsyCap, in my opinion, is so important, is the role of time perspective, also as another psychosocial pathway between socioeconomic position and health outcomes. What we see a lot in research, so it's been established in multiple countries across the world, is that individuals with a lower socioeconomic position often have a different way of thinking about their lives in the present, in the past, and in the future. So Zimbardo, the famous Zimbardo of the Stanford Prison Experiment, he also was influential in developing his research line on time perspectives and how people think about their own being in the context of time, so the past and the future and the present. And this also factors into, again, economic research or organizational psychological research, in the sense that what you see is that individuals with a lower socioeconomic position tend to discount the future more. So future discounting means that you focus on smaller immediate rewards at the expense of larger future rewards. And so what you, if you translate that to health behaviors, what it means is that you don't see the value or the utility of engaging in health-related protective behaviors now to reap the benefits in the future as much as people with a higher socioeconomic position would. So what you see is that individuals with a lower socioeconomic position often have a present fatalistic time perspective. So they focus on these short-term, present, smaller rewards at the expense of larger future rewards, but they also have a fatalistic perception of health and disease, in the sense that they consider becoming ill or getting cancer, for example, as more due to fate or bad luck than something that you can have control over or prevent. And you can imagine that if you, for example, grow up in a family where your father died of a heart attack aged 55, and you know that you'll be heading in the same direction because you grew up in a family with certain values and norms, you have a lower education, you have similar type of job as your father, you also may think, well, I'll die when I'm 55 or 60 as well, so why should I give up smoking? Why should I not enjoy my life as long as I still have it? Whereas individuals with a higher socioeconomic position, they are more likely to realize that maybe living healthy now may be beneficial for your life after retirement, for example. So if I try to eat healthily, if I try to exercise regularly, I may be able to prevent having certain types of cancer. Like Anna, at the very beginning of the lecture today, mentioned a lot of the diseases that we see in globally and the causes of death are preventable. They are preventable death. They are preventable diseases because they are very closely related to health behaviors. But if you don't see the value of engaging in these health behaviors because you may not see a future for yourself, then the likelihood of engaging in these behaviors also becomes very small. So time perspective in that sense is important. And what we try to, or my reasoning in my research is really about how can we try to stimulate individuals with a lower socioeconomic position, whether they are employees or students, to consider the future more in terms of it makes sense to engage in health-related behaviors now because you will reap the benefits of having a larger or a longer life as a healthy individual after your retirement, for example. And that is where, in my opinion, PsyCap really plays a big role because PsyCap is really about creating hope and optimism, about setting goals for yourself, building confidence and resilience in knowing that you can achieve a goal and that you can also deal with setbacks or conflicts or changes along the way to achieving your goal. And in a few studies, we've established that indeed this reasoning that we have, so the idea that there is socioeconomic position, then there is all kinds of reserves like PsyCap, financial self-reliance, life stressors, then there are time perspectives, and these are all related to self-reported physical health and self-perceived health. So this is actually looks like a very complicated figure, and it is in a way. This is a study that we did with a large sample, a very representative sample of the Dutch population, in which we identified socioeconomic position as educational level, having paid employment, and also personal disposable monthly income. So we actually used a few criteria to determine whether people were high, medium, or low in socioeconomic position. We measured PsyCap. We measured whether they felt they were able to engage in planning their own finances. And we also measured perceived life stress, which of course is very relevant also in the context of the reserve capacity model. We also added time perspective as measurements. Unfortunately, we didn't find as much as we had hoped. I really had hoped that future-oriented time perspectives would be related to higher socioeconomic position. and that those would actually mediate maybe between PsyCap and also health outcomes, or vice versa. As you can see, the actual relationships are a bit more complicated, but we did establish in this study, and also in the one I showed you earlier, is that PsyCap really buffers against the adverse consequences of having a lower socioeconomic position and having poor health outcomes. So if you can increase PsyCap and also some other psychosocial reserves, then the negative relationship that exists between socioeconomic position and health can, to a certain extent, be diminished. So PsyCap is really an important psychosocial reserve and pathway between SEP and health outcomes. And why I think it's so interesting is that it's really quite easy to increase PsyCap. So what we did was we based a future positive intervention, a micro intervention. We developed this together. And we based it on the principles of increasing PsyCap in organizations. And what Luthans and colleagues have established actually was that you can have micro sessions, which is like one workshop of 2 hours or 2 workshops of 1.5 hours each. And there are certain exercises that you can do as an individual that may allow you to increase PsyCap. And it starts with making a plan or setting a goal for yourself for the future. And then you make SMART goals to see how you can make it so concrete and achievable and realistic. But the basic principles of micro interventions to increase PsyCap are in this intervention that we developed called Future Positive. They were actually utilized to focus on health-related behaviors of lower socioeconomic position individuals. And I can show you the website. I do have to probably do a new share. Let's see, where's my internet? Can you see the website now, or can you only see my PowerPoint?
No, we still see your PowerPoints right now.
Okay. Then what I will do is I will open YouTube, because there's a small introductory video that we created.
That's nice.
I will also make the subtitles. I will just take a moment to do this.
Is it in the Netherlands, in Dutch, or in?
Yeah, but I can make English
Okay.
subtitles, or I should be able to. Here.
Massar, hey, ini Massar.
Can you see the screen?
Yes.
Can you see the video?
Yeah, that's great. Yeah.
And I will try to. So this is a brief example video of what we actually do in the, let's see, I'm going to share my screen again. So I hope that, yeah, the subtitle wasn't ideal, but what we try to do in these brief workshops, so we try to make it as cost effective and as easy as possible for the employees, but also for the employer, for the organization itself, to actually participate. So we hope that organizations will allow their employees to engage and participate during working hours. And what we do is we have a focus on increasing autonomy. So what I already told you is what we know is that individuals with a lower socioeconomic position, they have less feeling of having control over their lives. And this translates in also having lower perceptions of being able to determine their own health or disease. So they have these more fatalistic perceptions about what it means to be healthy or ill. And what we also know from the types of jobs these individuals have, in at least in the Netherlands, is that they tend to have very controlled jobs. So we engaged in, or we work together with a cleaning company, and these cleaners are told by their leader, by their direct leaders or foremen, the type of cleaning cloth they have to use, the type of cleaning materials they have to use. So their lives are sort of determined for them almost to the minute. And that is what they are actually used to. Also, you see that in the educational system in this country as well, that there is a learned helplessness almost among these individuals because they are exposed to so much control all the time. So what we try to do is we try to give them back a sense of autonomy, and we try to do that by increasing PsyCap. So if you think back to what PsyCap is, then this means that you focus on hope and optimism in setting a future goal. And what is really important here is that these individuals make their own choice about the specific health-related goal they want to achieve. So whether it is quitting smoking or losing weight or exercising more frequently, that is up to them. And that in that sense, they also have more of a sense of autonomy because they can choose what they want to choose, or what they want to change, and also what they think is relevant, but also how they want to change. So what the PsyCap intervention also focuses on is, so how do you get to this goal? What steps can you identify that make it possible for you to quit smoking, for example, or to reduce your cigarette smoking with to only 10 cigarettes per day, for example. And then they focus on creating resilience. So let's say you have colleagues who know that you smoke and who you have a break and they say, let's go out and have a cigarette. How do you deal with that? So how do you deal with social pressures? How do you utilize your social support network? So how do you get people engaged in, or at least how do you involve people in your own goal achievement? And how do you make sure that they don't hinder you, but actually help you in achieving your goal? So what we did was we did a few, I think every country and every organization probably was affected by the pandemic, but also we weren't able to do a full-scale implementation of the intervention. We wanted to implement it among at least 150 employees, and also to do a very extensive focus or process evaluation and effect evaluation afterwards to know okay, so did they achieve their goals, but also was PsyCap indeed increased? Did they report a more future-oriented way of thinking after engaging in this intervention? We weren't able to do that, but we did do a few pilots implementation. So we did have a few pilot tests of the intervention, and we developed the materials. We developed a extensive trainer manual as well. So the website Future Positive also, yeah, it's in Dutch, which is a shame, but you could see the video that I just showed you. We also have a few more videos about, for example, what smoking does to your body, but also what does it mean to live healthily. And Anna, you also probably recognize the fact that you need to have a certain level of awareness and knowledge about certain behaviors in order to be able to know what you need to change to be more healthy, for example. We also did a needs assessment in which we did focus group discussions and also interviewed other people from the organization. And what we also identified is that a lot of these individuals have issues with smoking. That's one of the biggest or the biggest health behavior that affects their general health. But they also report very bad quality sleep. So they don't have a lot of sleep, but also have very poor quality sleep. They have a lot of financial worries. And these in turn affect also how they think about their own health. They don't feel very healthy as people. So there is definitely a need for behavior change among this group. And we also did a process evaluation, or yeah, we asked them after the pilot test, so what did you think about the intervention? And they were very positive. They really liked the focus on autonomy and the focus on choosing your own goal and choosing also the path to get to the goal. They also liked the materials. They were very, they said we can recognize the visual materials. They really appeal to us. So yeah, the beginning is there. And we also know that they reported more hope and optimism after finishing the 2 workshop sessions. So in that sense, we also can sort of expect that if we would have done a large quantitative effect evaluation, we would have seen an increase in PsyCap, and maybe also hopefully a related increase in future-oriented thinking. This is actually everything I wanted to talk about today. I see we have some time left for questions, so I hope you liked the lecture. I'm happy to answer all the questions you have about this, but also maybe other issues related to social influence or social psychology or social determinants of health. And thank you for hosting me.
Thank you, Karlijn. I think someone has chat me about question in the first part of your lecture.
Okay.
Ask about before you talk about marital relationship, that this is influence our healthy behavior. It's like physically and mentally affected our state, right? But she said about what if the condition, if this is an unwanted marriage, wanted arranged marriage, unwanted and also arranged marriage. So it's quite complicated. Are the influence still exists? Thank you.
I think to a certain extent, yes, because what I know from the literature about arranged marriages and the development of intimacy and commitment and satisfaction with those relationships is that often over time, purely due to the fact that you are always around the same person, it creates a sense of not intimacy or commitment, but there is a way to a possibility to talk to another person. There is, of course, always the influence that we talked about, like the social facilitation, the modeling, the norms. But I can imagine that if it's a very unwanted arranged marriage, and if there's also a very violent, poor relationship in terms of psychological health, that these effects won't be positive to the extent that we saw in the graph. So, of course, this graph is based on data from the USA, where marriage is voluntary, where you marry someone because you like the person, because the person is similar to you, because the person, you fall in love with them based on shared interests, shared attitudes, shared outlook on life, values, norms. And in that case, I can imagine that if you are able to share your life with a friend, essentially, and you have this increased commitment and intimacy, it can have very positive effects on your health and on your life. But if that is not the case, and you have a very volatile, very psychologically unsafe relationship that you're exposed to on a daily basis, I can definitely see how this would have the opposite effect on health and well-being. Of course, there's a lot of gray area between having a very violent, unsafe arranged marriage and having an arranged marriage that is initially uncomfortable but develops into sort of a comfortable situation, in the sense that you get to know the other person, you become ingrained in each other's lives, you share small details about your life, but also larger issues in your life, you share at some point a family. That could have the same buffering and positive effects. Yeah, but there's a lot of gray.
Yeah. Okay, thank you. So it might have an effect if we share the same value, and this is having a positive effect on our mental health, mental status, then it will affect our psychological, our physical health, right?
Yeah.
Okay, thank you for your explanations. Yeah, she already said yes. She's understand with your explanation.
Good. That's good. Yeah.
She direct message me. Okay, as the second questions about this is interesting questions. You present a graph about women have average higher life expectancy than men, and earlier you showed the videos about the men that is risk takers.
Yes.
And then is that anything related with that or something?
Yes, actually that's a very very good observation. And yes, that is one of the reasons why women live longer. But the core or the basic reason is purely biological. Women have two X chromosomes, and men have one X and one Y, which is less stable. So two X's is, biologically speaking, more stable in terms of physiological makeup biology. We also know, for example, that miscarriages women suffer during pregnancy are more often boys that don't, pregnancies of boys that don't continue. Boys are often also, as children, boys are more often ill. They're more susceptible to have common cold or all kinds of diseases. And I think also because of their biological makeup, there's still a lot of debate about why is specifically women, because women do live really quite substantial longer years than men. Also here in the Netherlands, for example, I think the life expectancy is about, it's high, but it's still, there's a difference of 6 or 5 years between how long men and how long women are expected to live. It could be that men just use more energy because they have more muscles, or because, but I do know that the biological fact of having 2 versus 1 chromosome, that is, so 2 X's versus an X and a Y, is a big influence. But also, yes, men just take more risks. Men are more likely to engage in physical risks because they essentially have less to lose. If you look at women and men from an evolutionary perspective, what we know is that women are responsible for being pregnant, for childbirth, but also after childbirth for feeding, nurturing the baby. So it's as soon as a mother dies, a baby has a very poor chance of survival. You can still see that also in actually modern times, especially in developing countries. I know from my research in sub-Saharan Africa that if the mother dies, the baby has an almost 0 chance of surviving, even if it's adopted, or there's a family member caring for a baby after a mother dies. Whereas if a man dies, that influence on offspring or child survival is just much less present. So men are also more used to engage in physical competitions, or even fights, aggression, to compete with one another over access to women, or access to territory, to achieve status. And women are very hesitant to engage in any type of physical confrontation with either men or women, which makes them more likely to survive in the long term. So there are interacting processes, both at the really fundamental biological level, at the evolutionary level, but also at the simple behavioral and psychological level. So it's a complicated set of interacting processes that determines eventually that women live longer. And I really don't know enough about the research about this topic, but menopause in women may also play a role. It's really, if you compare females, so human females, to other animals, it's really weird that women live after they cannot have children anymore. In the sense that in all other animal species, except maybe elephants, women or females die after they have lost the ability to reproduce. And in humans, we have grandmothers, which are really important also in raising children and in childcare. So there's also that. So there are certain things inherent to being a man that determine longevity and survival rates, but there are also things inherent to being a woman which make you more likely to live longer.
Thank you for your answers. I think, yeah, it's interesting explanation. We are lucky because Karlijn also interesting to explore about evolutionary psychology and also gender relationships. So she came with this conclusion and explain in this point of view. It's so. Is there any other questions from the students? No. I would like to congratulate you for your work. It's like a very beautiful, very important work, and
Thank you.
Improve health behavior of people with a low social economic status. I mean, this is relatedly new for me because I imagine that people in a developed country, there's no such inequality or disparity in health. We talked about that because mostly this inequality or health disparity are because of health access that mostly found in a low and middle income country. Like for example, it is the case in Indonesia that there is low, very much expensive what is doctor or cost for visiting the hospital and so on and so on. So it's quite interesting to hear your explanations about that. And I'm just at the beginning, I'm imagining what can we do if the problem is just like that. And you tell us about the importance of psychological capital. And you prove that in your research. That's quite interesting how this psychological capital, like for example, self-efficacy, optimism, and what else? Resilience.
Hope and resilience.
Yes, have a huge impacts in our health behavior, our health status. Yeah, I think
and of course, I mean, what you also have to remember, and it's still difficult. I mean, we also received reviews and comments from other researchers that say, well, but why do you think that focusing on the individual will help? I mean, you have to also change things structurally on a very basic level. And that is also true. And that's also what we see here in the country, that a lot of the areas and neighborhoods where people with a lower socioeconomic position live are also not very conducive to exercising, for example. If you feel unsafe, if you go outside of your house because there is graffiti or there's trash or there's not a lot of green and it's not safe to walk because there's a lot of traffic, there's air pollution, then people won't go outside of their house and exercise, for example. So, and also related to that is the fact that if you don't have a lot of money, what I know here in the country is that unhealthy foods are cheaper than healthy foods. So it's cheaper to just buy deep fried fries and very cheap processed meats than to buy fruits and vegetables and eat healthily. So if you don't have a lot of money to spend, I can imagine that you would spend it on food that makes your children's belly full, rather than something that may be healthier, but your kids are still hungry because you just don't have the money to buy sufficient amounts of food. So there are governmental decisions that don't stimulate healthy living, and that are driven by a desire for profit and capitalism more than a desire to increase public health. So there are still, but I've always tried to be positive and optimistic in the sense that even if you can only change small things, and that's also what we try to reinforce in this intervention, this future positive intervention. Even if you can reduce the number of cigarettes from 25 per day to 5 per day, you already have profit in the sense that you increase your health. If you can just get out of the bus one bus stop before you would normally get out, you increase your physical exercise per day. So there are very small behavior change things that you can do to achieve ultimately quite large results in terms of health benefits. And I think that if you keep on making efforts to make people aware of that, and also to give them the tools, the cognitive tools, but also the social tools to be able to achieve those goals, then you can make a difference, even by focusing on the individual as a psychologist and not on the very large structural factors that are also, of course, they're very relevant. And I can definitely see how in a country like Indonesia and the research you did for your PhD, the access to, especially in the context of these kinds of diseases like breast cancer, if you don't have access to the basic healthcare because of income or other reasons, I mean, a lot of things end there. But on the other hand, there are still preventable or health preventative behaviors that could help, as well as screening and early detection. So yeah.
Yeah, I understand that's what you said, that small progress is still a progress, right?
Exactly. Yeah.
It's only in the individual level. We cannot always expect that it's always have a huge impact in every level. It's still a long way to go, but
yeah,
at least we already initiate a first step to
exactly.
To change.
Yeah, and we can also I mean, that's also what I try to do by giving lectures like these, is to really stimulate the young researchers of the future to also put efforts into trying to increase health, but also to just make the world a little bit better on all kinds of levels.
Yeah, that's also my expectation, also as a lecturer and also a researcher, that the young researchers like this student, you understand that this actually the disease that have high mortality number, actually it is preventable by behavior change process. So you know about that, and maybe you can have you can make a research that have impact on it. Yeah. I think that is the lesson that we can learn from today's lecture.
I hope so.
Yeah. Thank you so much, Karlijn, for your...
Very welcome. Thank you so much for hosting me. Have a good weekend, all of you. Thank you for being there.
Yeah.
And don't hesitate to contact me if you have any have any other questions or want to have PDFs of the papers, or I'd be happy to help out.
I think we already shared about it. If you like to discuss further with Karlijn, you could find her email. Maybe you can browse her name, Dr. Karlijn Massar and Maastricht University, and you will find her email, or maybe you could also discuss it with me.
Of course, Anna knows a lot as well.
Yeah, thank you so much, Karlijn.
You're welcome. Thank you.
Bye-bye, everyone. Thank you
Bye-bye
for your attendance.
Bye.
Bye.
Bunda.